the case for change. Why are we doing health links? Really, as our previous speakers have said, we've had these patients who are repetitively visiting the emergency room and getting admitted to hospital. And they're costing the health system a lot of money, and there's this potential to prevent these admissions and these emerge visits by wrapping around care in a coordinated way. 5% of the population costs 66% of the healthcare dollars in Ontario. We have that very small little 1% that are probably not avoidable. Those may be the dialysis patients, the chronic ventilation patients and such, but there's that other chunk which is avoidable. It brings everybody together in that coordinated way so that everyone who's touching the patient and the patient wants involved in their care has a means of coordinating their care and communicating regarding their care. Ideally, we want to improve the health of patients. So why coordinated care plans? Well, it's based a little bit on international experience, but let's talk about Quebec. There was some work done where there was 200 patients done through coordinated care plans. Patients reported improved well-being and feeling healthier. 72% reduction in emerge visits and 83% reductions in hospital admissions. Very large statistics when you look at that. So we want to get community-based providers all together, increasing the coordination of the care, reducing use of healthcare across the system, and in primary care we want to coordinate that essentially in a better, more organized way, and that's really the ultimate goal of health plans. The best way to look at this is looking at a patient. This is my patient John, not his real picture, of course. So I was asked to sort of present a case, and this guy just automatically jumps in my head when I think COPD because it's been a long struggle in the last year. So I'm going to present a bit of background on him. So he's an 84-year-old gentleman. He's a widower. His wife died about 6-7 years ago of multiple myeloma, and he's been living alone in this apartment kind of at Richmond, Oxford, very close to downtown in London. He has a 120-pack-year smoking history. So figure that out. He's 84 years old. 2 packs a day for 60 years plus, right? Has hyperlipidemia and restless leg syndromes. Otherwise, not a lot of other chronic disease problems. We talked about, Kelly mentioned 4. Well, this guy only really has 2 chronic disease problems at this point. So this is kind of a chronology from October 2013 to October 2014. I put this in particularly because over this time period there have been a lot of talks about how things coming to fruition and obviously the delays in getting these business plans together, and I kept thinking this guy needs a coordinated care plan. So 7 hospital admissions for COPD. The second admission, he was diagnosed with bacterial endocarditis and ended up with IV antibiotics for 6 weeks at home. So attached to the PICC line on a chronic manner. CCAC nurses coming in every 8 hours to put in a new bag of IV antibiotics. He had multiple ER episodes to the point that I could even count them in the lens notifier. I'm going to say at least 40 in that period. Sometimes there would be 2 or 3 in a week, then eventually would get admitted. He's been on home oxygen since May 2012. His best FEV1 that we can find is 31%, so he's pretty severe. And he still smokes, about 5 cigarettes a day. Right now, just from Med's point of view, he's on Spiriva, Advair, Crestor, Ramipril, aspirin, and Cinemet. He ended up on the Ramipril after his endocarditis because I felt he may have had a little bit of a small infarct related to that. So he has only family members, his brother-in-law. This is his wife's brother who's trying to help out. Him and his wife never had children. He has no close relatives around. They're all living in other parts of the country. His brother-in-law found him in October 2013 on the floor. He was confused, and that precipitated his admission to hospital. When the paramedics came on his oxygen, his O2 sat at 78%. So he was quite obtunded based on his COPD exacerbation. So at that point, after the 3rd visit, they started getting the CCAC Rapid RN involved. And that helped because we got blister packs set up from the pharmacy, so that was one of the major recommendations. However, we had the oxygen company involved, and one day they came in to check on him, and he was smoking wearing his oxygen. And they basically wrote this official letter to him and to me, CC'd me, saying that if he doesn't stop smoking, we're going to take away his oxygen. We cannot do that. The irony of it all is about 10 years ago, I actually had a patient who died in a house fire from smoking with their oxygen on. So this was lit up to me as really being a big issue here. He's seen 5 internists and 3 respirologists through his 7 admissions, because he's going through London Health Science Center, and every time you get with a new team. As a result of these missions, both a general internist and a respirologist have been following him for a COPD, not CCing each other. So he's got 2 specialists following him. Interesting. I was seeing him on home visits when I could. A lot of talk about placement. His brother-in-law really wanted him to go into a nursing home. We felt it was good, but he did not want that. So this was a guy who really, all the people who were touching him weren't communicating well. And we really, he also had the DNR over at home after his 4th admission. So just going back, this was a guy who really needed somebody to look at his coordinated care plan. What did he want? He wanted to be home. What was precipitating his emerge visits? Often he'd be up at night feeling short of breath. He'd have difficulty getting to the washroom. He would push his lifeline, and emerge people would come, or somebody would get called. The ambulance people would come. He'd say, I don't want to go to, and they say, you have to go, and he would get taken to emerge. Sometimes he would phone 911 and say, can someone help me? And of course, what's it for? Well, I don't know. He was just basically, he wanted help. He was lonely too. There's multiple issues. So this guy needed a coordinated care.